Acknowledge and pay our respects to the First Peoples, the traditional custodians of the lands and waterways. We recognise their spiritual and ongoing cultural connection to country. We respectfully acknowledge elders, past and present, and thank them for their wisdom and guidance as we walk in their footsteps. Well, good afternoon and welcome everybody to this confirmation of candidature for IPPE HDR student Jordan Woolley. On his panel today is his principal supervisor, Dr. Emma Bradshaw, co-supervisor Dr. Anthony Dillon, and also Professor Rich Ryan. On today's CoC expert panel is chaired by Associate Professor Bojinder Sadra and expert panelist Professor John Marshall Reef and Associate Professor Keon Yap. So without any further ado, Jordan, I'd like to hand over to you. Thank you.
Thanks, Ricky. Let me just share my screen here. Does that come up for everyone? Okay, perfect. All right. So firstly, thanks for taking the time to attend today, everyone. I really appreciate it. By way of introduction, I am Jordan Woolley. I'm a psychologist for the Greater Western Aboriginal Health Service. Essentially, we're a health service that has clinics in Western Sydney, the Blue Mountains, Central West New South Wales. We also have a residential rehab facility in Moree as well. And so my proposed thesis is on the application of SDT for problematic alcohol and substance use. One note I will just make from the outset is that I use the word substance use in this presentation to be a very all-encompassing term. So basically referring to any psychoactive substance, whether it's from nicotine through to opiates like heroin, alcohol, anything that where it can produce a substance use disorder, whether that be alcohol or anything else for that matter. And without further ado, let me introduce you to the study. So I'm looking at essentially how SDT-based interventions can be used for substances and investigating their efficacy and the mechanisms of change. So SDT has been shown to be effective in a lot of different domains of health. So physical activity and sedentary lifestyle interventions, dental interventions, screen time, and meta-analyses have found typically significant, albeit modest effect sizes on health behaviours. One of the challenges that we do have with the existing literature is there is a lot of heterogeneity. So we know, for example, in SDT-based interventions that settings and characteristics of participants are important. And if we look at those meta-analyses, one of the challenges is that effect sizes are pooled for interventions as diverse as, brush your teeth more, is alongside, a cannabis use disorder. And obviously, they're two different types of participants likely to have different motivational profiles, and settings are likely to be quite different. So there is a lot of heterogeneity there, which does mean that we have a lot of important questions. So the meta-analyses they pull all of these different types of interventions. We don't know specifically for substance use how effective these interventions are. And also as well, in terms of participant types, most of the existing studies have looked at non-clinical settings. So when we talk about, within the context of this presentation, clinical participants, we're looking at people who would meet diagnostic criteria for a substance use disorder or an alcohol use disorder, according to DSM-5 criteria. So the heterogeneity does give rise to 4 questions. So one is how effective these interventions actually are in substance use, the extent to which clinical status moderates the efficacy of interventions, the types of SDT-based interventions that are most effective, and who is most likely to benefit from them. When I talk about types of SDT-based interventions, I should just give a bit of an introduction. Essentially, there are 2 broad categories that tend to exist in this domain. One is a motivation-based intervention that directly targets identified motivation for behaviour change in substance use. And the other is a needs-based intervention, that's really about helping to support people in the satisfaction of basic psychological needs for autonomy, competence, and relatedness. And then as a result of the satisfaction of those needs, there are improvements in self-regulation and motivation as well. That comes as a byproduct. So these questions are going to be addressed through 3 proposed studies. So the first of which is a meta-analysis, then a cross-sectional study, and finally a randomized clinical trial. So study 1 will be the meta-analysis. It will investigate SDT-based interventions in substance use and potential moderating factors, so particularly clinical status and intervention type. Second study is that cross-sectional one, which will investigate the relationships between basic psychological needs, so contextual factors, and personality, so trait factors in substance use and their relationship to clinical status. So really that follows on naturally from study 1, because if we identify what we expect to find in study 1, which is that clinical status does moderate the efficacy of substance use interventions for SDT, then the logical question that follows from that is why? What is it about these participants? What is it about that particular type of sample that makes it more effective? And the hypothesis that we have is that it's going to be that those who are in who have clinical status have greater levels of need frustration and also personality factors. So impulsivity is the main one that I'm looking at, higher levels than the non-clinical participants. Study 3 is a randomized clinical trial that follows on from study 2, testing the effects of a need-supportive intervention on substance use and looking to see how those factors change, trying to investigate how they interact, how impulsivity and needs frustration interact, and how they actually are responsible for clinical change, therapeutic change, sorry, I should say. All right, so one way of conceptualizing it is that these 3 studies address these 3 questions. So firstly, to what extent do SDT-based interventions help? Then who do they help most and why? And how effective are they in a clinical sample and how do they work? The reason it matters is that almost goes without saying that substance use represents a huge percentage of the global burden of disease through direct effects on health outcomes, but also secondarily through mental health and impairment in a bunch of different domains, from employment to relationships to education outcomes across the board. Most interventions use contingency management, or they target the cognitive underpinnings of addiction, or they address skills deficits. So for example, DBT addresses emotion regulation, motivational interviewing directly targets motivation, identified motivation in behavior change for substance use. Whereas this proposed research will generate new knowledge of the association between both trait and contextual factors within substance use, and that has implications for design of interventions and also for risk assessment. So then meta-analysis in study 1, already outlined the aims there. First hypothesis is that SDT-based interventions will reduce substance use. The literature is pretty clear on this, that this should be the case, just we will clarify the size of the effects. Secondly, that the intervention will produce, that needs-based interventions will produce larger effects than motivation-based interventions. Rationale for that is that motivation-based interventions might be perceived as externally controlling. They might be experienced as such, whereas needs-based interventions target motivation indirectly. It's the changes in motivation and behavior are secondary to satisfaction of basic psychological needs, and so we expect them to be more effective. So as far as eligibility and method, so a structured literature review will be conducted amongst English peer-reviewed journals, looking at all the standard databases, so PubMed, psych info, so on and so forth. The studies that will be included will explicitly incorporate SDT constructs and will have substance use outcome measures. They might include measures of need satisfaction and frustration or clinical status, but if they don't have those, that's not an exclusion criteria. We'll follow PRISMA guidelines in the meta-analysis, and we'll do the analysis within R. Study 2 is this cross-sectional study. It aims to determine whether clinical and non-clinical groups differ on measures of frustration of basic psychological needs and impulsivity. And to look at potential interaction effects between those two factors. So this is really, again, following on from the first study, saying, well, if we find what we expect, that clinical status does predict better treatment response, why? What is it about these participants that makes them more, I guess, more amenable to receiving more benefit from the treatments? Now, I should just highlight, if we don't find in the first study in the meta-analysis what's anticipated, that is that moderating role of clinical status, then it does give rise to a whole bunch of different research directions. So that would be counter to what would be expected based on the existing literature. And there are a lot of questions that could then be addressed in a subsequent study around why that's the case. Is it that clinical status doesn't really, that's a poor proxy for the heterogeneity that's in the existing studies? Is setting more important? Are there other individual factors or contextual factors that we should be investigating? So I'm fairly confident based on the literature that we will find the hypothesized relationships, but if not, there are still plenty of places we can go afterwards. So just want to make mention of why needs frustration and impulsivity will be addressed as these factors that explain difference in treatment response in clinical and non-clinical participants. There's need frustration refers to, it's distinct from need satisfaction in the sense that it refers to the active thwarting of psychological needs. So a simple example would be parents who are draconian and ultra controlling and punitive in their discipline of a child. That is qualitatively different from someone who simply doesn't help to satisfy needs for autonomy, competence, and relatedness. And we know from the literature that needs frustration, whereas need satisfaction predicts well-being, needs frustration has been connected with maladaptive coping and aspects of psychopathology. As far as why impulsivity, impulsivity is interesting in the sense that it is, if you look at the literature on substance use, it is a lower order personality factor that seems to be associated with all sorts of substance use. So, for example, amongst other lower order factors, anxiety sensitivity is one. People with anxiety sensitivity, higher anxiety sensitivity, are, for instance, more likely to use alcohol to regulate their mood and affect and to cope. But they're not as likely to use, for instance, amphetamines. Someone who's more sensation-seeking might use amphetamines. Impulsivity is interesting in the sense that it seems to be positively associated with substance use across all substance types. So it's a fundamental biologically based marker for vulnerability to substance use. And there is emerging evidence that needs frustration, that the relationship between needs frustration and maladaptive coping, so for example in non-suicidal self-injury and in problematic gaming, that is actually mediated through impulsivity, and there seems to be a reflexive relationship there as well. It makes sense that someone who's high in trait impulsivity is likely to behave in manners that are likely to lead to frustration of their needs. So it makes sense that the relationship between needs frustration predicts poorer outcomes in self-regulation, and the dual track model of self-regulation, for which there's a lot of evidence. Trait impulsivity is essentially this effectively stable, relatively stable vulnerability that the expression of impulsive behaviours is modulated by the efficacy of top-down processes in self-control, which are undermined by frustration of basic psychological needs. So the choice of needs, frustration, and impulsivity makes sense when we're looking at trying to understand what it is about clinical groups that makes them more amenable to SDT type interventions. So first hypothesis in the study is that clinical status participants will have higher needs frustration than non-clinical participants, and that clinical status participants will have higher trait impulsivity than non-clinical participants, per the literature. Third hypothesis is that need satisfaction will be negatively associated with substance use for both groups, and the needs frustration will be positively associated with substance use for both groups as well. And that clinical status will moderate the link between needs frustration and substance use, such that the link will be stronger in the clinical group because they have greater needs. Finally, that clinical status will moderate the relationship between impulsivity and substance use, such that the association is stronger in the clinical group for the same reasons, and that the interaction effect of needs frustration and impulsivity will be higher. Sorry, needs frustration and impulsivity will interact to predict substance use, such that the link between needs frustration and substance use will be higher when impulsivity is high, again, because of that interaction effect. So in terms of methodology, I'm going to use a Qualtrics panel, a sample of 800 participants. I base that on power analysis, assuming a power of 0.9 and a P of 0.05, and assuming conservatively small effect sizes, so F squared of 0.02, and assuming that we use linear multiple regression with 3 predictors. Measures, the audit C and the DUDIT C, they're nice and brief, so appropriate for an omnibus survey. The basic psychological needs, satisfaction and frustration scale by Chen, and also the UPPSP, which is a measure of impulsivity that's commonly used in substance use research. And it's interesting because it measures 5 different facets of trait impulsivity. So urgency when under conditions of positive affect, urgency under conditions of negative affect, lack of premeditation, sensation seeking, so sort of novelty seeking type behavior, and lack of perseverance as well. So all these different facets of impulsivity, and expect some insights to come from that might be differentiated by different types of substance use. We'll exclude any severe psychiatric comorbidities, so any schizophrenia spectrum disorders, bipolar disorders, severe personality disorders, anyone with severe neurodevelopmental disorders or cognitive impairment, and data analysis will be in R. Third study is the randomized clinical trial. That would be within the service for which I work, and it aims to test whether the needs supportive intervention is more effective at reducing substance use in a sample of clinical participants compared to a control that are receiving therapy as usual. It's also going to test whether needs frustration and impulsivity moderate treatment effects in that sample. And we'll be able to see, I guess, live the mechanisms that are found within, hopefully identified within study 2, to see what that looks like longitudinally. So just a brief comment on the use of an Aboriginal sample. So Aboriginal culture, it seems to be an appropriate setting. So there is a lot of autonomy frustration within Aboriginal communities due to socioeconomic disadvantage, and government frameworks for effective engagement with these communities do support the importance of self-determination. Also, our Aboriginal cultural practices and their value for kin connection means that their cultural values are highly resonant with SDT, and it seems like a fitting setting for use for testing this sort of intervention. First hypothesis is that the intervention will have a moderate positive effect on reducing problematic substance use, per the literature. that individuals high in needs frustration in the treatment group will experience greater treatment effects than those with lower needs frustration due to greater need. And individuals high in impulsivity in the treatment group will experience greater treatment effects to the need supportive intervention than those with lower impulsivity. And again, this is due to this interaction effect of impulsivity and needs frustration, and through self-regulation, through self-regulatory failure. Fourth hypothesis, that impulsivity and needs frustration will interact such that individuals high on both are likely to experience especially larger treatment effects than those with lower impulsivity or needs frustration. So again, it's an RCT that'll be conducted at work. I have a tentative but probable sign-off from the executive within the service. It will be using the same measures as study 2. It'll be 200 participants based on power analysis with four time period samples. So the treatment group will be CBT plus the SDT intervention, and the non-treatment group will be treatment as usual, so just CBT. Data on all of the variables will be conducted at those 4 intervals, so 1 at baseline, 2 at mid-intervention at 6 weeks, 3 at end of treatment at 12 weeks, and 4 at follow-up at 16 weeks. And in all likelihood, we'll be using structural equation modelling in R with regression and moderation analysis, mixed effects modelling. So just harkening back to the 4 questions at the outset, so hopefully the proposed research will have clarified the efficacy of SDT-based interventions for substance use by removing that heterogeneity that we discussed, and also identified why clinical status is associated with larger effect sizes, the reason that that's the case, and who's most likely to benefit from it, and how those therapeutic benefits accrue. And it should hopefully, again, also have produced novel insights into the interaction of contextual and trait factors in substance use. That is pretty much it. So has anyone got any questions?
Well done, Jordan. So I'd like to hand over to Baljinder as chair to facilitate the Q&A. Thank you.
Definitely, yeah. Nicely done, Jordan. That was fast enough, really nicely paced. I understood everything. I didn't have to press double the speed on YouTube that I usually do.
Should maybe kept it to 1 coffee, or maybe 3 would have been better. So yeah, that's
all good. Very well presented. I enjoyed reading the written draft that you had submitted of your CoC. The theoretical background and rationale are largely clear. I have some questions. They are all designed to improve the study, hopefully, with that goal in mind. So I'll lay it out. The very first thing that jumped out at me when I read your document, and it came again when you were talking about your study in the talk, the use of clinical status, the term itself. You clarified it in your talk, and I saw it in your document as well. But I believe we need to kind of think a little bit about it. The reason, and I'll present my reasons for why I think it's problematic, and then you can tell me your thoughts. So you're a clinician. I was very pleased to hear that when you introduced yourself in the beginning, which makes my task a lot easier as we discuss this. You may already be familiar with some of the problems that have been identified with respect to the DSM disorder categories. So I won't belabor, but I'm assuming you're already familiar. There are lots of weaknesses of the DSM that people have been talking about. They're not new. They've been around in the literature for at least 10 years, some even more. It lacks specificity. There's a high degree of comorbidity. And most damning of all for me is that it lacks a predictive use in terms of predicting who's going to get better and who won't. So I'm very pleased to see that you are introducing this new theoretical framework, or at least adding to the CBT that's already there in the clinic, an add-on to it, using principles from SDT to promote health-related behavior or reduce substance use in those clients. So all of that is good, but the issue is, for me, using the word clinical status, even if you define specifically based on substance use related syndromes or symptoms, whatever term you wish to use. One problem is in your first study, you're using substance use as an outcome. And if I understand your model correctly, what you're saying is X, a predictor, which could be need, satisfaction, etc., frustration, impulsivity, etc. X is predicting Y, and Y in this case is substance use. But then you say that that's moderated by clinical status. But how is clinical status defined? It's by levels of Y. So you're saying X predicts Y, but it does so even more for certain levels of Y. That to me sounds like a polynomial regression model. But then you call it a moderation test, which makes it a bit confusing. So that's one issue, which is the methodological one. Easy to fix, but I'm just saying that this is kind of how it's coming across. The second is the clinical status, and you use the term clinical population a lot. You know, this and this is true. I'll give you specific examples from your, I can pass that on later, the feedback later. But the general point is, when you use clinical status as a general term, it gives the impression that it's a relatively homogeneous group. But as a clinician, you know that that's not the case. And you also know that even when using DSM categories of someone with such and such disorder, I don't know, some severe depressive disorder or something, they are not a homogeneous group, or a hoarding disorder. They are not a homogeneous group. And then given these differences and different syndromes, different diagnoses, you know, which is problematic, as you know, from that literature, and then putting everyone together and calling it the clinical population, again, creates a problem for me, especially when there are sentences or when you frame hypotheses, specific sentences, in which you say that these possible mechanisms are especially likely to be true in clinical participants. That is a problem for me because I don't know what is that population. There's refinement of language that's needed. And again, it's very much doable. It's not a damning, you know, it's not like a deal breaker or anything like that. It's a really good study. It's just a matter of fine tuning that language a little bit to clarify. And it would be useful to reframe the hypotheses of study one, just so it doesn't sound like that you're predicting Y, which is substance use, but then you're using something from Y then again to predict Y. There's some circularity in it that needs to be removed when you frame the hypotheses. Okay, but I understand why you would say that. I'm just saying that the analysis kind of need to be framed to better test your theory and your thinking in this area. So that's one piece. Actually, it's a couple of pieces kind of put together. In language use in terms of clinical status or clinical participants, and then fixing the hypotheses and the analytical angle that you have in your study one. For study two, again, I'm so pleased to see that you wish to do this in a naturalistic setting, in a clinic that's serving a very important need, likely to be very high impactful research. All of that is really good. One thing, again, it's a suggestion for improvement. As you are setting out your study design, you lay it out as understandably so, because the whole thing is about need satisfaction and SDT-related principles and how they can improve outcomes for these clients in that clinical setting. The problem is it sets up the expectation that you're setting the efficacy of this SDT-based intervention, which will be co-designed, I understand. But the problem is the design itself doesn't do that. The design is an added value design. Your comparison group is CBT, and then the intervention group is CBT plus SDT. So any conclusions that you make can only be SDT is going to be effective if added to CBT. From the basis of this study. If you really wanted to say the SDT part that you're designing is effective on its own, you need a nothing condition, like where no intervention is given to anyone, a wait list design or something like that. If that's what your goal is, that may not be your goal. So that needs to be clarified. Either you kind of clarify your goal a little bit or change the design. If you really wanted to, you could have three conditions. You could have a condition where nothing is given or a wait list control to participants, which is a genuine true baseline. And then a CBT condition and a CBT plus SDT, and then a separate SDT that has SDT alone. So that would be a lot of conditions to resolve all of those things. And maybe you don't want that, but that's something for you to think about and fix. Okay. Let me just very quickly see. There was one other thing. I wondered about feasibility, and that could be because I don't fully understand the context, and it's not possible to convey that in paper, all the details. So perhaps you could comment on it a little bit more, and I'll frame my question, then you can sort of explain that for the benefit of the panel. You're saying that you did power calculations and approximately 200 participants will be recruited, 100 per arm. Sounds great. Sounds great on paper. But I'm just wondering in that clinic, and then I looked at your timeline and you've got January 26 to January 27 allocated for data collection. So that's a year-long window for data collection. Probably okay, but I just have no sense of how many people walk into that clinic and how many of them will actually qualify to have that clinical, I actually don't even want to use that term. I'll get to that, why that's a problem in this case. But how many of them will have substance use related diagnosis? How about that? I'm going to call it that, which is critical for your study. Would you be able to give us a sense of the numbers that these, the Aboriginal Health Center or other places where you'll be recruiting?
Yeah, look, I understand on the face of it, it seems like a big number. One thing I would say is I am reasonably confident around feasibility from a participant number perspective because we do have a lot of sites. Now, the site that I'm based in, which is in Western Sydney, has hundreds of people through every day. And it's through a combination of different services. So there's an elders support service, there's the medical centre itself, and then there's a social and emotional wellbeing program. There's that. Plus, we also have in the mountains as well, a smaller clinic. And in Wellington, in the Central West, there's a fairly large clinic there that would see similar numbers to Western Sydney. And likewise, there's a residential rehab in Moree. It's a small residential rehab, but they're kind of a captive audience in some respects. So there are, I'd say probably 10 to 12 that would come from there. So that's a fair percentage of it. So as far as the number of people who would,
but presumably some of these are, revisitors, like coming that they've been seen once and then they're coming again and again. So hundreds in a day would mean. So let me reframe my question. How many new patients would you get, let's say, in a month's time?
Yeah. Look, it'd be really difficult to quantify that. I would say that, yeah, there's definitely a lot of repeat visitors. But the other side of the equation is a very large percentage of them do have substance use difficulties. So I do think, if we're to look at it over a 12-month period, looking at breaking it down to about 8, 9, say 10 to allow for some attrition, 10 per month, I do think that's quite feasible. That'd be...
You're saying 10 new patients per month that would qualify, that would have some substance use diagnosis?
Yeah. Yes.
Okay. So if it's 10 per month, so how many in a year?
North of 100. So, and
that's I'm just trying to do a rough math with you to gauge feasibility.
Yeah, understand. Look, if we're to break it down in terms of intervention length, now again, I need to do more work around what that looks like specifically, and I completely agree with your comments around waitlist versus otherwise. But I suspect that there should be at least enough for three intakes over the course of the year. I currently have I think between 10 and 20 per month is feasible.
Okay. Okay, that's something to maybe consider a bit more. I mean, I don't think it's a deal breaker. I just don't have full information. I have a question mark there, and it's something that you and your supervisory team would explore a bit more and make sure that part is tightened a little bit as you move forward. That's my recommendation. But before I stop, I have one more kind of at the risk of belaboring this point, but it's kind of critical for study 3. You have the design that you presented is clinical status versus non-clinical status. These are the two groups, and then they receive CBT or CBT plus SDT. Why would anyone who is non-clinical receive CBT?
Yeah, so in study 3, they have study 3 is looking at that all of them are treatment. So they're all clinical in study 3, but there's TAU, and then there's treatment as usual, which is just CBT, and then CBT plus SDT. But they're all, and I take on board your comment around clinical status. I think the language around that definitely does need to be cleared up. But yeah,
there's no clinical group in study. There's no non-clinical group in study 3, right?
Yeah.
Okay, so, but in the write-up, at least, it's actually uses that terminology, and hence my question. Let me just see if I can grab. It's pages 23 to 24 in your write-up. That's where it kind of comes up.
23 to 24.
Yeah, that's where I kind of, you have screening assessments will be used to recruit for each group, parenthesis, clinical and non-clinical status. So these are the two groups.
That's a draft error.
That's caused my confusion.
I did. I'm sorry about that, Baljinder.
No, that's okay. That's okay. These things happen. It can be easily fixed. And in your talk, and then you clarify in the write-up, you do clarify that clinical status is defined by using the diagnostic criteria for an alcohol or substance use disorder, using the DSM. You do clarify that. And then you say irrespective of comorbidities. And again, as a clinician, you're sensitive to this. I gather you're sensitive to this. Comorbidities are rampant. There's a very high degree of comorbidities. Related to that, one final comment. And again, once you fix the clinical population language, many of these problems will disappear. But I'll give you another example. You say impulsivity is likely to be especially a problem for clinical populations. For me, it's kind of hard to see. How about someone's with the severe depressive disorder? Are they impulsive too? They have trouble getting out of the bed every morning. So it just doesn't work. All of it has to do with the fact that there's an assumption that there's a relatively homogeneous group when you know as a clinician that that's actually not the case. I'll stop, but with just one housekeeping, actually just a couple that I need to clarify, just so we know when we are discussing in the panel. In study 3, in the timeline that you presented, you say that you will submit ethics application in November of 25, and you'll start recruiting in December of 25. That's not going to happen. And the reason for that, it takes months to get clearance. So you'll have to kind of fix some of that.
I'm an optimist.
Yeah, very optimistic. Just way too optimistic. Yeah.
Delusional. Yes.
And the budget is missing. We need to sort of say something in your form. Would you clarify what's the budget and how are we supposed to think about that?
Yeah. Look, I think so for study 3, there'd be no cost. Study 1, there'd be no cost because there's existing data. Study 3, because I'd be collecting it from our service. Study 2 with the Qualtrics panel, I suspect probably around $3,000 or $4,000. I think.
Okay, so a budget will have to be submitted. for us to sort of tick that section of the form.
Okay. Okay.
I'll stop bugging you. Overall, a great effort. I really appreciate that you're doing it in a setting, clinical setting, trying to serve a genuine need and trying to make an impact. Well done.
Thank you.
I'll next
Thanks,
invite John Marshall for any questions or concerns.
Okay, thank you, Ginger. First, Jordan, I really like the both the written document for a CoC. I thought it was terrific, both practical and theoretical. I like the presentation, so very positive. I had 3 concerns. I'm really worried about the time. Let me see if I can get one in. We'll see if we can get to a second or a third. One for study 1, one for study 2, one for study 3. So the first question is, you know this better than I. What makes substance abuse go up or down? Especially, how do you, sorry about the term, how do you cure or reverse substance abuse? To me, I think it's a medical condition. You know better than I do. So my question is, how do you go from a psychosocial intervention, relationships, beliefs like identified regulation, to actually substance abuse reduction? What's the mechanism? I don't understand it.
Yeah, it's a great question. It's amazing how often that clients will actually explicitly connect them. So, for example, I relapsed. Jordan and I had a lapse. I smoked cannabis throughout the week. I was feeling really lonely. My partner left me, and my friends wouldn't answer my calls. So I've been smoking cannabis all week or drinking, or autonomy. Particularly in the socioeconomic demographic that I'm working with, their autonomy is constantly undermined, and to be, I can think of a few mechanisms by which it could work. So one is like the practical means of connecting with people who are promoting their salience of autonomy over the things that they do have control over. So oftentimes there's this spillover of, look, I don't have a job, I don't have any funds, and I can't do anything. And it's then, well, actually there are things that can be controlled. There are things that you are in charge of. There are adaptive decisions that you can make, and reinforcing adaptive decisions as well. If you do something that's good, if you're taking a step that's helpful for you, really reinforcing it and acknowledging it and promoting that sense of competence. So I think it is absolutely a medical condition, but there is definitely this cognitive and affective underpinning there. And I think that the medical aspect of it, I mean, I looked at a lot of the literature around the genetic vulnerability, and it's around 50% twin studies find, and there's a huge component of it, but the psychosocial factors definitely have a bearing on the extent to which that's expressed.
Okay, thanks for that. Just so I can go quickly, study 2. I'm worried about the design a little bit. You have a correlation with need, frustration, impulsivity, and substance abuse. And what it's a cross-sectional correlational design. And what I'm worried about is, I'm sure everything is going to be correlated, and the study will work out. But the interpretation, 2 things. There's a third variable problem that, like, I can just think of a negative emotion, neuroticism, something like that, a third explanatory variable that's not measured. So I would just encourage you, for the sake of time, I'll just say, I encourage you to think about a third variable problem and think about a research design that's not cross-sectional. I know these are going to be correlated, but what you're interested in the order of things. So consider some time waves, at least 2. So how about that with a quick, and how about last comment on study 3? I love need supportive interventions, but it seems like what you need is a non-need thwartive intervention. So why not do a non-need thwartive, low frustration intervention? That's just an open question.
I need to get my head around what that would look like.
Yeah, me too.
That makes sense. And I mean, it makes sense on the face of it. That sounds really like a very helpful insight. I just need to do some digging around how to actually do that.
In the interest of time, sorry to interrupt. I think we only have 5 minutes left, and we also have to deliberate. I saw Keong join. Keong, do you have any questions for Jordan before we ask him to leave? And
yeah, first of all, apologies for my lateness. I was held up at a meeting, and I attended from study 2 onwards. So I'll make some comments and queries, but very quickly. First of all, I just want to say, just from the write-up and also the presentation, well done, Jordan. You write well, you present well. I do agree that there are some questions. I do have some questions about this, your attempts at categorizing your participants in study 2. And in a way, it almost seems like you're reducing you're changing a continuous variable into a categorical variable, when I'm wondering if you need to do that. Also, in study 2, I noticed that in the introduction, there are a few mediational models that you present as evidence, but then you're testing moderation here. Yeah. And I was expecting actually a design whereby you're looking at impulsivity being the mediator between need frustration and substance use, or something like that. But that you then flipped around to become a moderation, and I'm wondering if you're going into a longitudinal design like John Marshall is suggesting, if you are, then a mediational design mediational analysis might be a useful thing to consider. In study 3, why isn't basic psychological need satisfaction tested as a mediator? Isn't that your, yeah?
It's I guess the logic underlying it is that a need supportive intervention increases satisfaction of needs, and then you get the treatment effects. So it's trying to sort of demonstrate the mechanisms by which the need supportive
random assignment.
Yeah.
I can see the problem, and I can see why there's a suggestion about another intervention. I'm wondering if measuring change in psychological need satisfaction might be a way around it, so that you can look at, because CBT might improve your psychological need satisfaction as well, and you might, and maybe there are variations in the change in psychological need satisfaction with one that focuses more on that. And
all of this,
I don't know. Yeah.
All of this feedback makes a lot of sense. And I mean, the sort of dichotomous thing between clinical and non-clinical, in the back of my mind, I mean, your comment, Hyung, around turning an interval into a categorical variable, I think, I mean, it makes sense, and I agree that it's not optimal. The rationale for it for me was, okay, looking at the shortcomings with the meta-analyses and seeing, and because the clinical status in some respects is, and again, I hate the term too, but it's in some respects like a proxy for all of these other factors. So, for example, you know, an intervention in the setting's likely to be different. You know, the clinician is likely to be different. The physical environment is different. Their understanding of why they're there and their level of engagement is likely to be different. And it's almost like a catch-all proxy, but I agree at the same time, there is something uncomfortable about it. And I get, Baljin, your point around comorbidities as well, particularly, you know, with borderline personality disorder, for example, characterized by impulsivity. It introduces all of these confounds. So I don't know whether it's a case of, and this is something I need to think through, whether it's a case of just changing the language to eliminate the idea of statuses and of clinical status and make it more about thresholds. So above certain thresholds on certain measures, for instance, and it doesn't sort of imply anything else in relation to their presentation.
Stay close to your measurements that you'll be safe. Yeah.
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 I'm so sorry. We are
sorry.
running out of time. It's 1:30. I really hate to cut this off because it's very interesting. We have one question from the audience, and if it's okay with you, Jordan,
Sure.
can we field that? This question from Herb, and then we'll ask everyone and you to leave. And I'm so sorry for the panelists that we have to stay a little bit longer. We started so much late. So Herb, do you want to ask your question?
Hi, Jordan. I just had a couple of quick comments reinforcing things. There seems to be confusion between mediation and moderation, and it's very difficult to test mediation when you've got a cross-sectional study because you're assuming that there's a causal ordering, but these variables are almost for sure going to be reciprocally related to each other and other variables. So you need to clear that up. The intervention is difficult because I assume you're working with a captive audience where they're all getting CBT, so that you can't have a no treatment control. That would be nice if you can build that in, but maybe that's not possible. But I do agree that you should have an interim need satisfaction measure because your intervention should have a big effect on need satisfaction, which then relates to your outcome. And if your CBT has as much an effect on need satisfaction as your intervention, it's your need satisfaction intervention, then you would predict probably that it has a big effect on outcome as well. So I think that you'll be doing really well by having a need satisfaction measure interim as a take measure for the effectiveness of your intervention. I'll stop there.
That makes sense. I can do a wait list, by the way, wait list control. So
that would be much stronger.
Okay, great. Thank you. Ricky, is there anything you need to do before we kick everyone
that's it.
out?
I'd like to thank you for your time and thank everyone for their time. So I just asked the panel to stay on. Well done, Jordan. Thanks very much.
Well done,
thanks,
Jordan.
everyone. Thanks, guys. Thank you.
Stop recording.